Hello friends, welcome to our channel SmartView. Hope you all are doing well as usual. If you are new to our channel, then please feel free to share and like our videos and subscribe our channel to never miss a future update from our side. Press red color subscribe button and never forget to click bell icon near to it so that you can receive all updated notification from our side. Now let's discuss Sacrococcygeal Teratoma, also known as a SCT. Let's see first introduction. Introduction of Sacrococcygeal Teratoma. It is a teratoma derived from a primitive streak derivatives and arise at the base of coccyx and sacrum. The tumor is composed of all three germ cells layers, that is ectoderm, mesoderm and endoderm. It is the most common congenital germ cell tumor diagnosed in infants and children younger than 4 years of age. Incidence is 1 in 35,000 to 40,000 live births. Female to male ratio is 3:1 to 4:1. It is more common in girls. Now let's see the presentation of Sacrococcygeal teratoma. It can present mainly in the three clinical patterns. First is fetal tumor present during the prenatal ultrasound exam with or without maternal symptoms. In second case, the neonates with large external predominantly benign lesions. And in third, children between the infancy and 4 years of age with predominantly malignant lesions arising primarily within the pelvis. Sacrococcygeal teratoma is usually discovered either because a blood test performed on the mother at the age of 16 weeks of gestation shows a high alpha fetoproteins AFP amount, or because a sonograph is performed because of uterus is larger than it should be and can be externally growing towards the skin or internally growing towards the pelvic organ. It can lead to fetal hydrops and demise, preterm labile polyhydramnios. Also, cesarean section might be necessary for fetal delivery. Neonatal growth presents as the sacrococcygeal exophytic teratomas. Infants and children presenting late usually have the internal variety of palpable per abdomen or imaging showing the displacement of a bladder of the rectum due to the mass arising from the sacrococcygeal regions. The presentation is older age groups is very rare. Now let's see the classification of sacrococcygeal teratoma. Sacrococcygeal teratomas are classified morphologically according to their relative extent outside and inside the body. Classification is given by Altman and is as follows. Type 1, Altman includes entirely exophytic sacrococcygeal teratomas. Type 2, nearly entirely exophytic. Type 3, mostly to the inside. And type 4, that is entirely inside, also called a retrorectal teratoma or a presacral teratoma. All of the four classification you can see in this picture, and the proportions in percentage wise is also given in these pictures. Type 1, that is entirely exophytic, is 45% of all the sacrococcygeal teratomas, while type 2, that is a nearly entirely exophytic, that is a 34%. Type 3, that is a mostly to the inside, and it accounts for 9% of all sacrococcygeal teratoma, while the last and type 4, that is entirely inside, also known as the retrorectal teratoma or presacral teratoma, that accounts for 10% of total sacrococcygeal teratoma cases. The Currarino triad, due to the autosomal dominant mutations in the MNX1 gene, consists of a presacral mass, usually a major teratoma or anterior meningocele, anorectal malformation, and sacral dysgenesis. Serial ultrasound and MRI monitoring of sacrococcygeal teratomas in fetuses in utero has demonstrated that the Altman type can change over time. As the tumor grows, it can push between the organs and through the peritoneum to the body surface, where the tumor appears the bulge is covered only by skin. Sometimes the tumor bulge later slips back inside the peritoneum. Discuss the malignancy risk of various sacrococcygeal teratoma types and their conditions. Like all the teratomas, a sacrococcygeal teratoma has the potential to be malignant, and the standard of care requires long-term follow-up by an oncologist. Masses presenting at birth or within the tumors of the birth are more likely to be benign, whereas the masses after the ages are the more likely to be malignant. When the tumor is found before the 1 month of age, the risk of malignancy is about 5%. When the tumor is discovered between 1 and 12 months of age, the risk of malignancy is 60%. While in children older than the 1 year, 75% are the malignant tumors. Now let's discuss diagnosis of sacrococcygeal teratoma. Symptoms can be presacral mass, constipation, urinary difficulties, bowel obstruction, hydronephrosis, and so on. A solid or cystic mass on a presacral ultrasound are growing internally or externally. Other tumors can occur in the sacrococcygeal and or presacral regions and hence must be ruled out to obtain a differential diagnosis. This includes extraspinal ependymyoblastoma, neuroblastoma, and rhabdomyosarcoma. Smaller sacrococcygeal tumors with an external component seen in prenatal ultrasounds or at birth often are mistaken for spina bifida. Cystic sacrococcygeal teratoma and terminal myelocystocele are especially difficult to distinguish. MRI is useful for difficult cases to diagnose it. Now let's discuss diagnosis as far as the prenatal period is concerned. In prenatal period, there are mainly three investigations which proves very useful. That is, first is the ultrasonography, second is the MRI, and third is the fetal echocardiography. Now let's discuss the first investigations, which is proves gold standard in the sacrococcygeal teratoma prenatal diagnosis. That is the ultrasounds. As I said, it's gold standard, and it's excellent detection rate found for the type 1, 2, and 3 because type 1, 2, 3 are tumors which are found externally to the fetal surface, while the type 4, which is entirely inside to the pelvic cavity of fetus, that is an intrapelvic tumor, so it cannot be very easily assessed on the ultrasonography. The average detection time is 23 weeks of gestations. We can assess based on the size, site, content, that is a cystic versus solid, growth patterns, and intrapelvic extensions of tumor. And based on this assessment, we can plan our method of delivery in future. During the prenatal ultrasound, an sacrococcygeal tumor having an external component may appear as a fluid-filled cyst or a solid mass sticking out from the fetus body. Fetal sacrococcygeal teratomas that are entirely internal may be undetected if they are small. Detections or at least suspicions is possible when the fetal bladder is seen in abnormal positions due to the sacrococcygeal teratoma pushing other organs out of place. Now let's discuss the MRI part of the investigation in prenatal period. MRI mainly used as an adjunct to the ultrasonography, and we can assess the tumor compositions very clearly and very precisely, whether it is a cystic or a solid or mix of cystic and solid, and in which proportions it is cystic and solid. The better assessment for intrapelvic and intra-abdominal extensions of the tumor we can done by MRI. Additional fetal malformation also can be assessed on MRI. We can discuss the third part, that is the fetal echocardiography as an investigation in prenatal period for a diagnosis of sacrococcygeal teratoma. Sensitive test to determine how hard the heart is working. And cardiothoracic ratio also can be assessed by this fetal echocardiography. If hydrops does develop, usually in the rapid growing solid tumors, the fetus usually will not survive without the immediate intervention before the birth. Let's discuss the postnatal part of the investigations as far as the diagnosis is concerned. Firstly, it is obvious that the fetal will be delivered in postnatal period, so we can assess clinically. That is mainly in case of type 1 to 3. That is in type 1 to 3 we can see the external parts of sacrococcygeal teratoma, so it can be easily assessed by clinically. But type 4, which is a mainly and entirely resides inside the pelvic cavity of fetus or neonates, so it cannot be very easily assessed. We can use MRI as a precision point to confirm the and how to plan the surgery in future assessment. CT scan also has the same indication as a MRI, and we can use for the confirmations of a solid versus cystic parts of this tumor. At birth, the usual presentation is a visible lump or mass under the skin at the top of the buttocks crease. If not visible, it can sometimes be felt and gently prodded. It feels somewhat like hard-boiled eggs. A small sacrococcygeal teratoma, if it is entirely inside the body, may not present for years until it grows large enough to cause pain, constipation, and other symptoms of large mass inside the pelvis, or until it begins to extend out of the pelvis. Even a relatively large sacrococcygeal teratoma may be missed if it is internal because the bony pelvis conceals and protects it. Mediastinal tumors, including teratomas, are similarly concealed and protected by the rib cage. Some sacrococcygeal teratomas are discovered when the child begins to talk at the about age of 2 years and complains of their bottom hurting or feeling poopy when they ride in a car seat. Part of the sacrococcygeal teratoma patients. If the baby's conditions is stable with no high output cardiac failure, that is a fetal hydrops, pregnancy will be followed with the regular ultrasound monitoring. If the sacrococcygeal teratoma is small, a vaginal delivery at the term may be planned. If the sacrococcygeal teratoma is large or if there is an excess of amniotic fluid, that is a polyhydramnios, an early cesarean section is planned to avoid tumor rupture as well as the risk of preterm labor and premature delivery. If the fetal hydrops develops, it may be a candidate of fetal surgery. The risk and complications of the sacrococcygeal teratomas. When a prenatally diagnosed sacrococcygeal teratoma is associated with the fetal hydrops, the tumor can become life-threatening to both mother and baby. The researchers have found that those sacrococcygeal tumors that are largely cystic, that is a fluid filled, generally do not cause a problem for the fetus before birth. However, when the sacrococcygeal teratoma is made up of mostly solid tissue with a lot of blood flow, the fetus can suffer adverse effects. This is because the fetus heart has to pump not only to circulate blood to its body, but also to all the blood vessels of the tumor, which can be big as the fetus. In essence, the heart is performing twice its normal amount of work. The amount of work the heart is doing can be measured by the fetal echocardiography. This sensitive test can determine how hard the fetus heart is working when the fetus is approaching hydrops or heart failure. If hydrops does develop, usually in rapidly growing solid tumors, the fetus usually will not survive without immediate interventions before birth. This fetus must be followed very closely and may benefit from the fetal surgery. In severe cases, the tumor steals blood from the fetal circulations, causing the heart to work extra hard and making cardiac failure possible. Cardiac failure exhibits as fetal hydrops, a massive accumulation of fluid in the body of the fetus. Fetal hydrops associated with the sacrococcygeal teratoma are rapidly progressive and nearly always fatal. Now let's discuss in case with the extreme fetal hydrops, the mother may be at the risk for maternal mirror syndrome, in which the mom's condition parallel and mimics that of the sick fetus. When the fetal hydrops is present, the mother may mirror the sick fetus, becoming ill with the signs of preeclampsia. Because of a hyperdynamic cardiovascular state, the mother develops the symptoms that are similar to the preeclampsia and may include vomiting, hypertension, peripheral edema, swelling of the hands and feet, proteinuria, that is a protein in the urine, and pulmonary edema, that is a fluid inside the lungs. Despite the dissections of a fetal sacrococcygeal teratoma, maternal mirror syndrome may still occurs. Preeclampsia, also called toxemia, is a condition characterized by the pregnancy-induced high blood pressure, protein in the urine, and swelling due to the fluid retentions. The complications of a mass effect of a large sacrococcygeal teratoma may include hip dysplasia, bowel obstructions, urinary obstructions, hydronephrosis, and hydrops fetalis. Even a small sacrococcygeal teratoma can produce the complications of a mass effect if it is a presacral, that is Altman type 4, in the fetus. Severe hydronephrosis may contribute to inadequate lung development. Also, in the fetus and a newborn, the anus may be imperforate. Later complications of the mass effect and/or surgery may include neurological bladder, other form of urinary inconsistence, fecal inconsistence, and other chronic problems resulting from the accidental damage to the sacrifice of nerves and the muscles within the pelvis. The removal of the coccyx may include additional complications. In one review of 25 patients, however, the most frequent complication was unsatisfactory appearance of surgical scare. The late complications of sacrococcygeal teratoma. Late effects are of two kinds: consequence of a tumor itself, and consequences of surgery and other treatment for the tumor. Complications of not removing the coccyx may include both recurrence of teratoma and metastatic cancer. Late malignancy usually involves incomplete excisions of coccyx and are adenocarcinoma. Although the functional disability in the survivors is common, a small comparative study found on a non-significant difference between the sacrococcygeal teratoma survivor and a matched control group. In a rare case, pelvic scarring may necessitate that the pregnant woman who is a sacrococcygeal teratoma survivor deliver her baby by the caesarean section. Now let's discuss the treatment part of the sacrococcygeal teratoma. Treatments involve the surgery to remove the tumors. Depending on the diagnosis and the severity of the child's tumor, they may undergo fetal surgery to remove the tumors before birth, or they may have tumor resection surgery after they are born. The severity of sacrococcygeal teratoma is directly related to the size of the tumors and the amount of blood flow to the tumor. Both the size and the blood flow can now be accurately assessed by sonography and echocardiography. The fetal surgery is only indication when the fetal hydrops is present, putting your child's life at risk. Complete surgical removal after the birth through the perineal or abdominal approach. The preferred approach to the small sacrococcygeal teratoma is through the perineum. A large sacrococcygeal teratoma may require additional approach through the abdomen. The procedure includes resections of inbound parts of the coccyx and sacrum and reattachments of the muscles that are attached to these bony segments in the usual cases. If not, there is an increased risk of a perineal hernia later in life. The rare cases in the older age groups should be resected without the bony resection if possible. Of the sacrococcygeal teratoma of adult. The sacrococcygeal teratomas are very rare in adults, and as a rule, these tumors are benign and have extremely low potential for malignancy. These estimations of potential is based on the idea that because the tumor existed for decades prior to the diagnosis without becoming malignant, it has a little or no potential to ever become malignant. For these reasons, and because coccyxectomy in adults has a greater risk than in the babies, some surgery prefer not to remove the coccyx of adult survivors of the sacrococcygeal teratoma tumor patients. There are cases reported of good outcomes. Now let's discuss the management of fetal sacrococcygeal teratoma tumors. Management of most fetal sacrococcygeal teratomas involves watchful waiting prior to any treatment and often used decision tree as follows. First, perform detailed ultrasound examination including fetal echocardiogram and Doppler flow analysis. If fetal high output failure, placentomegaly or hydrops. If fetus not mature, perform pregnancy terminations or fetal intervention. And if fetus is mature, then perform emergency cesarean section. Else no emergent problems, perform serial non-stress test and ultrasound biophysical profile and plan delivery as follows. If emergent problems develops, return to the top of the decision tree. Else if sacrococcygeal teratomas over 5 to 10 cm or polyhydramnios, perform early, that is 37 weeks of gestation, elective cesarean sections. Else sacrococcygeal teratoma tumor small and no complications, permits term spontaneous vaginal delivery. Emergent problems includes maternal mirror syndrome, polyhydramnios, and preterm labor. Poor management decisions, including interventions that are either premature or delayed, can have their consequences. A very small retrospective study of 9 babies with sacrococcygeal teratomas greater than of 10 cm diameter reported slightly higher survivorship in babies remaining in utero slightly longer. In many cases, a fetus with a small sacrococcygeal teratoma under the 5 or 10 cm may be delivered vaginally prior to the advent of prenatal detections and hence scheduled C-sections. 90% of babies diagnosed with the sacrococcygeal teratoma were born full term. Now let's discuss the fetal interventions. Fetal interventions is only offered to women in whom there is an evidence of a heart failure in fetus. Women who have fetuses with advanced hydrops, placentomegaly or maternal preeclampsia, that is high blood pressure, protein in urine, that is proteinuria, are not candidates for fetal interventions, as the researchers have found that these symptoms, that is the so-called mirror syndromes, indicates an irreversible situation. If the hydrops develops after the 32nd weeks of pregnancy, the fetus may be delivered for intensive management after birth. Before 32 weeks of gestation, fetal interventions may be advised to reverse the otherwise fatal heart failure. Two approaches towards the fetal intervention are possible for fetuses with hydrops: minimal invasive surgery and open fetal surgery. Minimal invasive fetal surgery involves insertions of a needle through the mother's abdomen and uterine wall into the blood vessels that feeds the tumor. Radiofrequency waves are used to destroy the blood vessels, and without a blood flow, the tumor does not grow and heart failure, that is hydrops, is reversed. However, the damage caused by the probe itself may be difficult to control. Another method of cutting off blood supply flow to the tumor is injections of drugs, for example, alcohol and substances like the EAT, that cause blood to clot. None of these methods has so far proven effective in all cases. Open fetal surgery is an alternative option. In this case, the mother's uterus is open under the general anesthesia, and probably very high general anesthesia, that by we can prevent labor, and the fetus sacrococcygeal teratoma is surgically removed. What will happen after birth? All babies with sacrococcygeal teratomas should be delivered at the specialized hospital with the pediatric surgery expertise. Tumor larger than the 10 cm diameter will require a C-section delivery. Neonatologist will provide supports in the intensive care nursery until the baby is stable enough for surgery. Surgical removal of the small tumors is straightforward, but removal of large tumors can be very difficult and dangerous. The baby may require a blood transfusion or transfusions and intensive support for days or weeks after surgery. Most will get through this difficult period and enjoy normal life. All babies should have yearly blood test for elevated alpha fetoproteins, which can signal recurrence of the tumors and possibly the malignancy. If the tumor is quite large and the surgeon performs an extensive complicated removal, there is an increased likelihood of long-term issues. A few babies may have difficulty with urinations or stooling. I hope this video was helpful, and it was. Don't forget to click the thumbs up button and share these videos with at least one of your friends to help them as well. If you have not only subscribed to the channel, considering the subscribing to get notified when we will upload the next video. Do leave comments below. I love hearing from you. I will see you in the next one. Till then, take care. Bye bye. Have a nice day ahead. Friends, stay tuned. Next parts of this video are coming on channel. Thanks for the discussion. Have a nice day ahead. Goodbye. Bye bye.